Hi everyone, my presentation is on body dysmorphic disorder or BDD. In the DSM-3, body dysmorphic disorder, previously called dysmorphophobia, was included as an atypical somatoform disorder and it did not include diagnostic criteria. Dysmorphophobia first received diagnostic criteria in the DSM-3R and the name was changed to body dysmorphic disorder. In the DSM-4, it was still classified as a somatoform disorder, and its delusional variant was classified as a psychotic disorder. In the DSM-5, BDD is listed as part of a distinct category, obsessive compulsive and related disorders, along with OCD, hoarding disorder, trichotillomania, and excoriation disorder. The reason for the reclassification of BDD from placement in anxiety disorders to its placement with obsessive compulsive and related disorders was mainly to include repetitive behaviors. The following criteria are used to diagnose BDD. Criterion A states that there is a preoccupation with one or more perceived defects or flaws in physical appearance that are either not present or appear as slight to others. They believe these defects make them appear ugly, unattractive, abnormal, or deformed. Preoccupations can focus on one or many areas of the body, most commonly the skin, hair, or nose. However, any part of the body can be the focus. The preoccupations are intrusive, unwanted, usually difficult to control, and time-consuming. They occur on average for 3 to 8 hours per day. Criterion B states that at some point of the disorder, the individual performed repetitive behaviors or mental acts in response to their appearance concerns. The individual feels driven to perform these behaviors, which may even increase their anxiety and dysphoria. Criterion C states the preoccupations cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. Individuals with BDD have difficulty with intimate relationships, as well as academic and occupational difficulties. And Criterion D states that these preoccupations with appearance are not better explained by concerns with body fat or weight and fail to be better explained by an eating disorder. Clinicians can also specify BDD with muscle dysmorphia, and this is diagnosed if the individual is preoccupied with the idea that his or her body build is too small or insufficiently muscular. Individuals with this form of BDD actually have a normal-looking body or may even be muscular. They may also be preoccupied with another part of their body that they also perceive as abnormal. Clinicians also use specifiers to indicate the degree of insight the individual has regarding body dysmorphic disorder beliefs. Many patients with BDD believe their self-perceptions are accurate and their concerns are appropriate. They tend to believe that others can see their deformations. On average, insight is poor, and 1/3 or more of individuals currently have delusional body dysmorphic disorder beliefs. The average age at onset for BDD is 16 to 17 years old, and the most common age at onset is 12 to 13 years old. Around age 12 or 13 years, subclinical BDD symptoms begin, and these concerns usually evolve gradually into the full disorder, but some people experience an abrupt onset of the disorder. Clinical features of the disorder appear similarly in children, adolescents, and adults. BDD does occur in the elderly, but little is known about the disorder in this age group. Individuals who experience the onset of BDD before age 18 years are more likely to attempt suicide, have comorbidity, and have a gradual onset of the disorder. Among U.S. adults, the point prevalence is 2.4%. Outside of the U.S., prevalence is approximately 1.7 to 1.8%, and prevalence may also be higher in college student populations. BDD is usually chronic. However, when treatment is used, some improvement is likely. If BDD is fully and appropriately treated with pharmacotherapy and psychotherapy, the prognosis is generally good. However, many people do not seek treatment for BDD because of guilt or shame, or they do not know their symptoms can be treated clinically, in which case the prognosis is poor. There's a 20% probability of full remission over 4 years with treatment, but 40% of those recovered will relapse, and the probability of remission decreases with greater symptom severity at presentation. Because of this, almost all individuals with body dysmorphic disorder, especially when untreated, experience impaired psychosocial functioning and an extremely poor quality of life. BDD has been reported in the U.S. and internationally. The disorder may have similarities across cultures, however, cultural aspects may influence symptom presentation to some degree. Similarities in cross-cultural aspects to BDD can be seen in Japan in a disorder known as Shubo Kaifo, and in China in the syndrome Koro or Suyang. Different cultures may have variations in beauty standards, therefore cultural factors may play a role in which body parts are of concern and how other symptoms of BDD are expressed. The etiology of BDD is complex and the research is limited, therefore the causative factors that lead to the development of BDD are not entirely clear. However, there is preliminary evidence that suggests sexual, emotional, and physical abuse in childhood may be associated with the development of BDD. Etiologic theories for BDD that have been suggested include sociocultural, cognitive behavioral, and neurobiological theories. Social interactions can be a source of childhood adversity that could play a role in the development of BDD. Ridiculing one's physical appearance can have a long-term impact on an individual and negatively impact their thoughts and emotions. Once an individual makes an association between the appearance of a feature and others' reactions to it, everyday experiences can continue to develop these thoughts and emotions, and it's theorized that this can contribute to symptoms of BDD. I previously discussed most of the cultural factors in the cultural considerations section, but this basically goes back to how culture may play a role in which body parts are of concern to the individual with BDD. A lot of these cultural factors have not been studied in relation to BDD, but there is evidence that standards of beauty appear to cross culture and emerge in early development before individuals even experience the influence of culture and media, making it questionable how large of a role culture actually plays. Looking from the cognitive behavioral perspective, people with BDD have thoughts that are self-defeating, as well as cognitive distortions and disastrous beliefs about their appearance. We can look at cognitive behavioral learning models of BDD. Operant conditioning, which is based on reinforcement and social learning, leads to the development of values and beliefs about attractiveness and appearance, which may play a significant role in the development of BDD. Then looking at classical conditioning, negative events involving one's physical appearance may act as an unconditioned stimuli and cause an unconditioned negative response. After BDD symptoms have been established, it is hypothesized that secondary operant conditioning in the form of negative reinforcement results in the maintenance of these negative behaviors and cognitions. Some neurobiological factors involved in the development of BDD include visual processing. Individuals with BDD appear to be more likely to notice minor deviations from beauty standards than others, and it is these neuropsychological deficits that are related to an excessive focus on detail and a sensitivity to perceived flaws. fMRI studies have shown that individuals with BDD may have perceptual distortions because they process visual information in an abnormal way, resulting in them perceiving defects in their appearance that are not observable or only appear as minor to others. There is also a genetic component to BDD. 8% of patients with BDD have a family member with a similar disease, and 7% of patients with BDD have a first-degree relative with OCD, suggesting that BDD is heritable and it might share a genetic predisposition with OCD. There's no clear explanation to date for this, but in addition to the factors previously discussed, co-occurrence may be explained by genetic factors. Despite limited research, there was a study on specific gene involvement in BDD, and it showed that there was a specific allele that occurred more frequently in BDD subjects than controls, giving additional support for a genetic component. There are a number of assessment tools that can be used to screen for, diagnose, and assess the severity of BDD. I've listed a few of those here from the International OCD Foundation's website on BDD. There are a significant number of differential diagnoses for BDD listed in the DSM-5, but before considering differential diagnoses that concern other disorders, one of the most important things for a clinician to do is confirm that the individual is not suffering from normal appearance concerns and clearly noticeable physical defects. Differential diagnoses include eating disorders, obsessive-compulsive and related disorders, major depressive disorder, anxiety disorders, and psychotic disorders. Below each of these are some ways to differentiate between these disorders and BDD, and there is also additional information in the handout. The key aspect that differentiates BDD from these other disorders is that BDD is entirely focused on appearance, whereas most of these other disorders are not, even if appearance does play a role. BDD is currently understood to arise from a combination of biological, psychological, and environmental factors. Treatment for BDD usually involves a combination of cognitive behavioral therapy and pharmacotherapy. Antidepressants can be used to improve some symptoms of BDD, such as suicidality and quality of life, which is particularly seen in more severely ill patients. This diagram shows a stepwise pharmacotherapeutic approach to BDD, starting with the use of selective serotonin reuptake inhibitors, or SSRIs. Discontinuation of medication entirely is strongly associated with relapse, so as long as symptoms improve, medication maintenance is strongly suggested. If discontinuation is chosen, it should be done gradually over several months. CBT approaches for BDD include various techniques such as behavioral exposure, cognitive restructuring, and response prevention. An additional therapeutic treatment I came across as an alternative to CBT is narrative therapy, which conceptualizes clients' problems as restraining narratives that are influenced by one's culture. Basically, it helps patients reframe their narratives regarding their problems, such as with their appearance, and lives by reflecting on the influences of their culture. The patient's restraining narratives are replaced with more empowering ones about their life. The emphasis is placed on addressing the diversity of the patient. Despite having a number of treatment options available, treatment is often a challenge for individuals with BDD. A major issue, as previously mentioned, is that people with BDD do not know that treatment exists and therefore they do not seek it. Another challenge is that patients may request odd treatment hours to avoid having others see their perceived defects. And patients with BDD may poorly adhere to treatment when it requires them to encounter others who they think will ridicule their perceived flaws. Now for a case presentation. Beth is a single 27-year-old white female with no children whose plastic surgeon at her local hospital suggested she seek counseling at the mental health clinic after she visited him for the 10th time that year. Beth has visited plastic surgeons across the country to try and find one who will operate on her hands, which she perceives as too big and too fat. She believes her hands make her so hideous and grotesque looking that she is not worthy of living a good life. Beth has never had any serious relationships and she avoids social activities. She barely made it through high school and opted to get her college degree online. Beth works from home as an IT specialist, where she can do everything over the phone or computer without showing her hands. Beth states it was not until she was around age 12 that she really started to focus on her hands, but since this time she has spent about 5 hours a day preoccupied with them. She checks her hands in proportion to the rest of her body in the mirror several times a day, and she will not leave the house without wearing gloves or a shirt that she can use to cover her hands. Beth reports no prior mental health treatment. Beth would be diagnosed with body dysmorphic disorder with absent insight or delusional beliefs. Beth hits on all of the criteria for BDD, and she experienced the onset of symptoms around age 12. If we look at criterion A, she is clearly preoccupied with her hands and spends about 5 hours a day focusing on them and their perceived defects. Nothing suggests to us that these defects or flaws are real, and this is supported by the fact that no surgeons will operate on her hands. For criterion B, Beth performs repetitive behaviors and mental acts, such as checking the mirror. She also wears gloves or long-sleeve shirts to cover her hands, and she has spent a significant amount of time trying to find someone who will perform a cosmetic procedure to fix the perceived problem. In regard to criterion C, Beth's preoccupation with her hands clearly causes her significant distress and impairment. She did not attend college in person, she avoids social interaction, works from home, and she has an overall poor quality of life. And as for criterion D, her appearance preoccupation is not better explained by an eating disorder. Beth has absent insight or delusional beliefs because she is completely convinced her body dysmorphic beliefs are true. A differential diagnosis for Beth could be social anxiety disorder or social phobia, but all of Beth's fears regarding being out in public or social interactions stem from her perceived appearance flaws. It is not the social event or actual interacting with people that gives Beth anxiety or a fear of them scrutinizing her overall, rather how people will treat her because of her perceived fat hands. Because of these reasons, Beth would be diagnosed with BDD, not social phobia. I hope you found this presentation on BDD informative. Please let me know if you have any further questions, and here is a list of my references. Thank you.